Welcome back to part 3 of the female chapter 56. And we're going to move on with contraception via devices or barrier methods. And you'll see outlined in this graph, much like the one with the hormonal chemical contraceptives, you'll see your vaginal ring, which vaginal ring is a method of introducing estradiol into the vagina. It's sort of a combo, if you will. It does have chemical associated with it, and it's changed every 3 weeks. It's placed deep in the vagina. It is typically a one size fits all. It does have risk of falling out, and if it does, we teach women to simply clean it with warm water and replace it within 3 hours. And if she doesn't, then the efficacy of it could be questionable. The IUD, or the intrauterine device, cannot be used on women who have diabetes or a history of pelvic inflammatory. We do know that one of the greatest risks is the risk for infection, and some of the side effects with IUDs is that women can report that they have unusually heavy periods and cramping when they do menstruate. So, and that can go opposite. We also have reports of women who have gentler periods. So there can be a change in the character of the menses for the woman who has an IUD. There are 2 types of IUDs on the market. We have a hormonal, which typically has a lifespan or coverage of 5 years. And then we have the copper, which covers 10 years. Your textbook does have a picture of what IUDs look like, and basically what they interfere with is implantation. So if there was fertilization, the interruption or the contraception is happening because the zygote would not be able to implant into the uterus wall. Big teaching with women for using an IUD is that they should always check frequently to see that the string is still in the vagina. They also need to know to monitor themselves for infection, foul-smelling odors, things like that from the vagina. Next one is the diaphragm, and the diaphragm needs to be fitted. It's most often used with spermicides, and ideally it would be placed 6 hours prior to intercourse, and it should be left in place for 6 hours post-intercourse as well. If the woman has a dramatic change greater than 10 pounds in her weight or has delivered a baby, she needs to be refitted for her diaphragm. So that's something that's important for her to know. And I think the biggest, diaphragms are relatively effective contraception when used properly. Spontaneity, sometimes for some women, that can be an issue. The next one is condoms, and these typically also would be used with a spermicide. And again, condoms, the important thing about condoms is the woman who's at risk for STIs. If she is at risk for STIs, condoms would be the recommended, and we know that they don't actually have as high an efficacy rate as some of the other like oral birth controls when used properly, or injections when used properly, or the IUD, but it does prevent her from STIs, and that's huge. And she can use that with another form of birth control to really cover herself for contraceptive, but we also want to recognize risk with STI, and that she needs to know, and her partner, how to use a condom properly. Your textbook does walk you through the proper use of a condom. And then finally, the spermicides, which come in many forms: gels, foams, creams, and these are typically used in conjunction. On their own, they're not efficient. They actually are not recommended as just the only form of contraception for women. So those are some of the more common contraceptive methods. The nursing care, again, reliability and knowing and understanding which methods are reliable. The most reliable method would be, excuse me, other than abstinence, which is difficult for many people to commit to if they're especially in a long-term relationship. But when we talk about interventions, would be the surgical sterilization that has the highest reliability. The benefits and the risks we've talked a little bit about, especially those risks like the DVT with the oral birth control. Knowing that we have to have this woman attend her routine health appointments and screenings so that she's monitoring how she's responding to her contraceptive of choice, STI management, again, condom would be the recommended method if she's at risk for STIs. And then the unreliable forms of birth control or contraception. Coitus interruptus, that's withdrawal or stopping in the middle, is absolutely unreliable. Douching, unreliable. Breastfeeding, absolutely unreliable. We know lots of women can be breastfeeding and still ovulating at the same time. We're now going to move into infertility. In order for a woman to be diagnosed with infertility, or a couple, really, this is about a couple, to be diagnosed with infertility, they have to have 12 months of active trying to conceive, active attempts at conception. And once they've hit 12 months, then we can work them up for infertility. Because there can be so many different factors that impact fertility, one of the first things that will be done is actually we'll do a specimen sperm sample from the male because it's easy to obtain and it's fairly easy to look at counts and then shapes and sizes of the sperm to rule out that it's male related. It can be male related, but it's very easy, and if that's what it is, then we save a lot of money and time working up the female. Some of the contributing factors for infertility could be structural, and a good example of that might be, everything's happening the way it should be, but we have an occluded tube. So therefore, we can't have a fertilized ovum working down that fallopian tube to the uterus. So that's just simply structure, and oftentimes we can do an HSG, that's that cell ping procedure to clear that tubal occlusion. They'll go in, they'll see it, they'll clear it, and that might be all that's needed. Sometimes it can be related to function. So function of one of the organs. So another good example would be endometriosis. So in the case of endometriosis, all these structures are there. They're all doing what they need to, except for that the uterus is not functioning properly because it's not sloughing. It's overproducing that lining, creating to this endometriosis where the woman now is having difficulty with conceiving because it's implantation. The endometriosis, she can't implant that pregnancy, she can't maintain it. Or the underlying cause could be hormonal. So structures are there, structures are functioning, but she has a hormonal shift. Her hormones are off, which isn't maybe triggering ovulation as it should be. And I have in parentheses there, obesity. There is a high rate of infertility in women who are obese, especially with BMIs greater than 29. And we oftentimes counsel women to simply lose weight, and we watch those hormonal functions begin to come back into normal. So that's a consideration in women who are battling infertility if they're obese. Already spoke about the male, could be male related directly to sperm counts or the way the sperm behaves. And then the other issues with contributing factors could be if we have lots of history of STI and PID, pelvic inflammatory disease, that also just the scarring can create a problem with conception. And then exposure. Women who are exposed to radiation or chemotherapies that can alter the reproductive tract function or hormones can also have issues with infertility. So the diagnostics that are surround infertility would be semen sample, as I said earlier, a pelvic exam, just to certainly examine the structures, perhaps an ultrasound, again, examining structures, HSG, that's that cell ping, to look at the tubes and see if those are patent. And then what I don't have listed there, and I should, is hormonal studies, which can be done and basically measure levels of their hormones to see that she is indeed ovulating and stimulating ovulation. The therapies for this couple would be, there's a number of therapies. I mean, sometimes the diagnostic procedure like the HSG will clear the problem in the tube, and that's really all that was needed. But oftentimes, if the cause is not clear or suspected to be hormonal, but it's not being captured, then there are subfertility medications that can be used, and you're not required to know what those are. This is an area of highly specialized nursing care Remember, we teach to the generalist here. But those pharmacological fertility drugs that I'm sure you've heard family and people throughout your communities may have taken, they do have a 25% risk of multiples, so twins, triplets, or beyond. So that's important for women to know, that they can be hyperstimulated with the ovaries. The AI is artificial insemination. This is a procedure, so where the woman is could be structural or semen related. So basically, we as a medical community or profession offer a direct intervention where the woman is artificially inseminated, and it's using the partner's sperm and her own ovary, and simply replacing the active intercourse is really what artificial insemination is doing. It's bypassing some of the structures that could be getting in the way. It is different than in vitro. In vitro fertilization is we've removed the ovum and the sperm from their natural environment within a vitro, a petri dish, a tube. Conception is achieved and then redelivered directly to the woman's reproductive tract, so that then she can grow her pregnancy. So different than artificial insemination, in vitro is. So nursing care for this population would be centered around psych support, education that goes along, especially with those pharmacological medications that they're taking, and then any of these therapies that might be happening for them, and perhaps even some genetic counseling may be involved. Sometimes infertility, we see that rate of infertility go up with advanced maternal age, or attempts to get pregnant. So there can be what we call a codependent or a coexisting factor of infertility, and then that potential for genetic changes. So the last thing we're going to cover here under the female considerations is menopause. And menopause, by definition, is a woman who has had cessation of menses for 12 continuous months. So it's an interesting definition, because many women who are between the ages of 42 and 55 will explain or detail phenomena that are oftentimes tied to menopause, things like hot flash, mood swings, lack of sleep, weight gain, bloating, fatigue. So these are all some of the complaints that we'll hear women report, and they believe that they're menopausal, but they're really not menopausal until they've gone 12 consecutive months without a menses. So some women will start to have sporadic or unpredictable menses cycles, where she may have a change in the quantity of menses. Maybe she's having metorrhagia or menorrhagia, right? That heavy or abnormal bleeding, or amenorrhea. She'll go 3 or 4 months and then she'll get it, another menses, and you can see where the predictability is now gone, and that can certainly be frustrating for women. But we won't say that she's menopausal until she says, I have not had a menses for 12 months. And that's important for us, because then we would characterize any bleeding beyond that point, even if it was 2 months later. Once she's gone 12 months, she should not have vaginal bleeding ever again in her life. And if she does, we must work her up. Why is she bleeding? So one of the first things they'll look at is the characteristics of the uterine wall, examining to see if it's thickened or changed. Remember, women, once they have experienced menopause, they've stopped ovulating, therefore their things are atrophying, her ovaries are atrophying, the uterus atrophies. It should not be thick. She's not preparing for a pregnancy anymore. And those can be indicators of perhaps a cancer, a uterine cancer. Hormone therapy may be offered to some women, but they have to do a safety assessment first as to whether it's appropriate. And nursing care for these women are typically supportive, seeing that we can help her get through some of those changes, like the hot flashes, daily mood swings. That is it for your chapter 56. I'll see you in chapter 57.